Hello and welcome to the very last pharmacology video that I will be doing. I'm so excited. Just like some of the last videos I've done, I'm not really going over any new drawings per se, but just kind of reviewing old things. And I do have some memory tricks for the new drugs. So with that, let's get started. And so we're going to begin with perioperative care. So before surgery, you want to make sure that your patients stop taking their aspirin, their clopidogrel, their prasugrel 5 to 7 days before the surgery. That way they're not bleeding out during your surgery. And then you want them to stop. You want them to stop their ticagrelor 3 to 5 days, their warfarin 5 days before, and then their apixaban, rivaroxaban, dabigatran, all of those 2 to 3 days before surgery. And then just as a side note, stop immunosuppressives also because that can, in taking immunosuppressions would increase the risk for post-op infection. So you want them to stop that 2 to 4 weeks beforehand. So here again is my pictures for aspirin. We had an aspen tree, and the key here is that there are 5 people sitting in this boat for 5 to 7 days before. And then I have a hoof print that makes the clop sound for clopidogrel, a proud seagull for prasugrel, and those are all right next to each other. So if you just want to remember the 5 people sitting in a boat and the 5 to 7 days before surgery, that's a good way to remember that. Ticagrelor, this was this guy named Greg, and he's choking on a Tic Tac. You could think that one way to help you remember that 3 to 5 days is like, I don't know about you guys, but when I eat Tic Tacs, I just dump a whole handful. I don't just eat one, I eat like 3 to 5, and I put all 3 to 5 of them in my mouth. For warfarin, so that's down here, you want to stop that 5 days. Don't have a good day, good way to remember that. And then here again is just my picture for apixaban, rivaroxaban, and dabigatran. So this is a really pixelated picture of a river. And then this is just like one of the transformers, like Megatron, dabigatran, sounds similar. Moving on to surgical prophylactics, like antibiotic prophylaxis. Most of the time you can use cefazolin, and so cefazolin is a first generation cephalosporin, which is shown here with the violin. So violin, cefazolin, and it has this little IV surgery. I can't think of what these are called, but anyway, it's to show you that it's IV for surgery. You could also use clindamycin. So this was a climber. Use climbing for clindamycin, or you could use vancomycin. If it is a GI surgery, then you want to use cefazolin plus metronidazole or fluoroquinolone plus metronidazole. So here's my picture of metronidazole, which is a person at the metro airport. And just as a reminder, the type of antibiotic that is going to be used will be based off the type of surgery, the patient's allergy, weight, and it can be given 30 to 60 minutes prior to surgery and or up to as a single dose up to 48 hours post-op. So after surgery, they're most likely going to have some post-op nausea and vomiting. And so you want to do a risk assessment just to see, are they at risk for post-op nausea and vomiting? So have they had this happen in the past, or do they have some other risk factors for that? And then if they do develop nausea and vomiting, here are your options. So you can use Compazine, which I have right here as the computer that has dopamine on it because it's a dopamine antagonist. You could use Reglan. So this is, again, Ronald Reagan smoking a doobie. Doobie for dopamine antagonist also. You have on Dancitron, which I'm going to skip for a second, scopolamine. So this is like a gun scope. So scopolamine is, there's little ACHs here. It's acetylcholine inhibitor. And then, of course, at this point, we should all know ondansetron, which is Zofran, which is a serotonin antagonist. You could also use dexamethasone, which is a corticosteroid. I think that's, I bolded it because I think that's interesting. It's not really a, anti-nausea drug. And then here are some drugs that I don't believe we've ever covered before. So this is a Prepitant and Fosaprepitant. And so that's what this picture here is. You're prepping food with your next of kin. So there's two people here, they're prepping food. So they're prepping food for a Prepitant or Fosaprepitant. And, it looks like they're maybe a husband and wife. So they're each other's next of kin. And the reason why I chose the word kin is because it is a neurokinin or a neurokinin antagonist. And adverse effects are headache and hypersensitivity. So I bet you if you were cooking with your next of kin, you at some point would probably piss each other off, give each other a headache, maybe someone would cry and be hypersensitive. So then now I'm going back to preoperative stuff. You can give midazolam or Versed to help with sedation and help the person forget things, so amnesia. And this is another one that I don't remember. I don't think we've covered. And so the brand name is Versed. So I said the vermin said, and that's what's being shown here. So there's this vermin or this rat, and he has a speech bubble because he's saying something. And of course, this drug is a GABA agonist. So everything that is a GABA agonist has garbage in the picture. And then the adverse effects are sedation, which is why, right, that's why I have a seed, and then amnesia, American cheese. But we are using this drug for its adverse effects. That's the whole point. And then you could also give analgesics such as morphine and fentanyl. So morphine to me sounded like morphing, like a morphing butterfly. And it's a vasodilator opioid analgesic. So this branch is vasodilating, and also the butterfly is morphine. So that's morphine. And then just fentanyl here is a fence for fentanyl. And then just another thing is you want to keep an eye on blood sugar management throughout surgery. So moving on to anesthesia, but we're going to start with local anesthetics. So the MOA for all local anesthetics is that they inhibit the initiation and conduction of nerve impulses by blocking sodium channels. So sodium channels is going to be our key there. There's many different types, and they differ based on their onset time, their duration, and then their type of chemical class. Some of them can be diagnostic, some of them can be used to treat pain, facilitate surgery. And then remember that epinephrine can be added to these drugs, which generally will increase their duration of action and decrease bleeding because it's a vasoconstrictor. So you have two types of local anesthetics. You have esters, such as tetracaine or pontocaine and procaine. So I just tried to find a way to remember the onset and duration. So pontocaine, I said, get ready to go on to the pontoon boat in 15 minutes. And pontoon boats have two pontoons on them. So onset is 15 minutes. We want to get ready to be on the boat in 15 minutes. And the duration is 2 to 3 hours. So 2 pontoons, 2 hours. Next ester is procaine or novocaine. And the onset is 2 to 5 minutes, and the duration is 15 to 60 minutes. This one is commonly used at the dentist office, and so I just think about if you've ever had a filling, it is pretty quick onset, 2 to 5 minutes. Then your other type of local anesthetics is your amides. So this is lidocaine, and it's very fast. It's within less than 2 minutes and lasts for 30 to 60 minutes. So lidocaine sounds like light ocane. And I think, you're speedy, you're fast like the speed of light. lidocaine, speedy like light, and that just means it is very fast, less than 2 minutes. For bupivacaine and marcaine, I don't have a good way to remember this, but the onset is 5 minutes and the duration is 2 to 4 hours. And it just occurred to me that I didn't explain this. Anything in blue are things that I haven't covered yet. Like I don't have drawings for them. And then everything in green is just my little memory tricks for you guys. So moving on to the actual intra-opt anesthetics. So what you have paralyzing agents. And so all of these are going to inhibit acetylcholine at the skeletal muscle receptor. And adverse effects are respiratory failure and hypotension, which I think is relatively easy to remember because when you are paralyzed, it paralyzes your diaphragm, so that's why you have respiratory failure. And I mean, most people, we are concerned about hypotension when they're in the OR. So next, there's two types again of paralyzing agents. So you have non-depolarizing and depolarizing. So for non, you have this atracurium or tacurium, and the onset is 2 to 3 minutes. Duration is 35 to 45 minutes. And so I wrote here after I ran track, I'm supposed to say, or run track, my muscles hurt. So track is for this tracarium, and your muscles hurt because this works at the skeletal muscle receptor. And if you are running, if you've ever ran track, you could aim for 2 to 3 minutes as your time around one lap of the track, if that's helpful or not. The other one is rocuronium, and this onset is 1 minute and the duration is 45 to 60 minutes. And so I said, let's rock right now around the clock. So rock around the clock, let's rock right now. This is very fast, onset of 1 minute. So that's why I said, let's rock right now. And then around the clock, because the max time here is 60 minutes. And so if you went around the clock, that's 60 minutes. Next is succinylcholine, which has an onset also of 1 minute and a very short duration of 5 to 10 minutes. And then a pro tip is just that you want to avoid this in patients who have hyperkalemia and skeletal muscle injury. I mean, that would make the skeletal muscle injury make sense because it works on the skeletal muscle receptor. So you wouldn't want to, it wouldn't be effective if you had skeletal muscle injury. And so the way to remember this is just, so succinylcholine, it sucks you into a hole, like really fast. I don't know, when you get sucked into a hole, like I'm thinking in my mind like a black hole, you just get sucked in and then, I don't know, it's just quick. Like, so it's quick because the onset is 1 minute and then the duration is very short as well. For intraoperative anesthetics, so now we're talking about general anesthetics, you have etomidate, which we have learned before, but so here it is. This is Tom. He's holding a date in his hand, and he's also holding the gavel because he was in court because it inhibits corticosteroid production in the adrenal gland. Cause adverse effects are hypnosis, myoclonus, that's why his is kind of like tremoring there, apnea, hypotension, and cardiac suppression. The next general anesthetic is propofol, or I wrote a propofol. So that's what this is here. These are like, you know, like if you were in a, obviously as a child, but if you were in a play and you wanted to pretend like you were riding a horse, this is your prop, and it's a foal, like a horse. And well, obviously, since this thing is fake, it doesn't feel pain. That helps you remember that it's an anesthetic. And eventually, you know, as a child, these things get broken and then they go into the garbage. And that is because propofol is a GABA agonist. Adverse effects are hypotension, apnea, hypertriglyceridemia, and injection site reactions. Another one is ketamine or ketelar, and so this is an NMDA antagonist. So it works as it helps with amnesia, analgesics, and it's an anesthetic. And the adverse effects are dissociative reaction, tachycardia, and hypertension. And so that is what this picture is here, because I think ketamine or ketelar, like, it looks like key. And this is one of those key rings that help you fight someone if you were like attacked. And so I think when I think of fighting, I think MMA fighting. And to me, MMA is similar to this NMDA. And if you were attacked and had to use your little fighting keychain, well, then you would probably be really nervous and therefore tachycardic and hypertension. So that helps you remember the adverse effects. I know that was a long stretch, but the next drug is dantrolene, which is for the treatment of malignant hyperthermia, which malignant hyperthermia is a complication of general anesthetics and succinylcholine. I don't have a picture or a way to remember that. So next, I just have the drugs that would be used in SRI or rapid sequence intubation. So you're going to push midazolam or Versed, or you could use propofol or etomidate or ketamine. And then you're going to give succinylcholine or etruscurium, that's supposed to say, or rocuronium, or another NMD. It's probably supposed to say NMDA. So I just bolded these two because rather than remembering a bajillion things, just remember Versed, succinylcholine. So now we're going to move on to just some ICU stuff. So in the ICU, you can use all kinds of drugs, right? You can use benzodiazepines, which, just as a reminder, is your lorazepam, diazepam, midazolam. And that's going to keep patients from fighting the ventilator, keep them calm. And so over here is my picture of some of our benzos. So like we have the Lorax for lorazepam, and he's vacuuming, and he's using the vacuum for Valium or diazepam. And there's a clown for clonazepam. So just things like that. And of course, he's vacuuming up the garbage because these are GABA agonists. Also in the ICU, you can use propofol again for sedation. You can use dexmedetomidine or Precedex, which is used for sedation also. This is a centrally acting alpha-2 agonist, which reduces norepinephrine secretion and produces analgesia. Adverse effects are hypotension, bradycardia, and hyperthermia. Now, I know I have a peach here, and I think that was supposed to correspond with this, and it had something to do with like a peach and a peach, like the beginning of this word, but it doesn't make any sense, so I don't know. So just ignore that. The next drug that you could use is haloperidol, which is for treating delirium and agitation. You can use narcotics for pain, such as fentanyl, hydromorphone, morphine. Your vasopressors to keep blood pressure up would be for epinephrine, which is an alpha-1, beta-1, and beta-2 agonist. And then norepinephrine, which is a beta-1 and a beta-1 and an alpha-1 agonist. And then phenylephrine, which is just an alpha-1 agonist, and then dopamine is beta-1, alpha-1. And again, all of these increase heart rate and contractility, and then also blood pressure. And so that is what this picture is for. So in this picture, we have this stream here. And in the stream, there's, of course, some fish. So you have a beta fish, and then you just have this normal, like, alpha 1 fish. And so there's a pine tree here with a big X through it for no pine. That's norepinephrine, and it's right next to the alpha 1 and the beta fish, the 1 beta fish, because norepinephrine is a beta 1 and alpha 1 agonist. If you follow the stream along, you have epinephrine, which is shown here by, and again, it's a pine tree. We're going to call it an eastern pine tree for E-pine, eastern pine epinephrine. And there's this squirrel that had to do with the adverse effects. Anyway, it's beta 1, beta 2, alpha 1. And then this alpha dog is eating a fennel plant. And he's an alpha dog, so he's an alpha 1 agonist. To reduce blood pressure, you can use nitrile furanide, nitroglycerin, labetalol, which is beta blocker, nicardipine, which is a calcium channel blocker. And then Professor Lau really emphasized that when you're in the ICU, you need to wash your hands because otherwise you're going to cause nosocomial infections, which if there is a nosocomial infection, it's most likely one of these. So Pseudomonas, MRSA, MERS, VRE, fungi, etc. So your patient's in the ICU, they're laying flat, they most likely had surgery, yada yada. They're probably a really high risk for DVT. So for DVT prophylaxis, just like pretty much everyone else, you can use enoxaparin, dalteparin, fondaparinux, heparin, stockings, and compression devices. If you are concerned about getting a stress ulcer, you can give them some prophylaxis for that, such as famotidine, which is a histamine blocker at the H2 receptor, and pantoprazole, which is a PPI, proton pump inhibitor. And so that is what is in here. So we have a family of snakes that are dining. So a family that is dining, that's famotidine. And because they are snakes, snakes go hiss for histamine. And then pantoprazole is shown here. These are all of our PPIs. And it blocks the final step of acid secretion, in the active pumps only. So I have this dude who is taking some steps and he's wearing pumps. He's also wearing pants, so pantoprazole. And then, of course, fluid management in the ICU. And then one last thing to consider is all of your acid-base disturbances. I am not going into this in too much detail, but just here's a reminder of your normal values. So pH should be between 7.35 and 7.45. If it's below 7.35, you're acidotic, and if you're above 7.45, you're alkalotic. For PCO2, normal range is 35 to 45, and it's nice because those line up pretty well. And the higher that your PCO2 is, the more acidic you are. And then the higher that your bicarb is, which normal range is 22 to 28, the more alkalotic you are. And so now we're going to move on to DKA. So things like risk factors or causes of DKA can be infection, it can be trauma, medication non-compliance, of course, because if you don't take your insulin in a week, your sugar is going to go really high. Things like MIs, strokes, pancreatitis, pregnancy, alcohol or drug use, especially cocaine abuse. So if you have someone with DKA, you want to get a bunch of lab values. You want to get potassium. You want to get their pH, their PCO2, their HCO3. Those are usually going to be low, of course, because this is diabetic ketoacidosis, so they're going to be acidotic. Their blood glucose, of course, is going to be really high. And then they're going to have a positive beta hydroxybutyrate, or BHB. You also want to check their magnesium and their phosphate. So treatment is IV fluids, regular insulin, potassium, and then consider bicarb. And so this is my picture that I made a while ago for DKA. So you want to give fluids first, and you want to give 0.9% normal saline, add dextrose once the sugar approaches 250. At the same time, or a little bit after, you want to be giving insulin. So this is an insect for insulin, and that is 0.1 units per kilogram, bolus per hour. And then keep their potassium above 4.0. So there's 4 bananas here to help you remember 4.0. I don't think you really need to know the numbers for now, but I had them from previous. And then to treat hypoglycemia, you can give D50, so dextrose, 50% IV, or you can give glucagon, which could be IM, IV. I don't know what that's supposed to be. Maybe intranasally. Anyways, glucagon, I thought sounded like a glue gun. So we have glue gun, and it stimulates gluconeogenesis and glycogenolysis in the liver. So that's why the gun is aimed right at the liver. You could also use octreotide, which I don't think I had a picture of previously. We have learned about it previously for the treatment of, I believe it was esophageal varices. But anyway, in this case, it is also going to work as an antagonist of pancreatic insulin release. So I have an octopus who's in a tree, octopus in a tree for octreotide. And there's just a pancreas to help you remember that it's a pancreatic insulin antagonist, basically. The adverse effects are diarrhea and abdominal discomfort. To treat status epilepticus, you want to use benzos. Again, lorazepam, diazepam, midazolam. Those are your first line, but then you want to give a secondary control benzo, such as fosphenytoin, valproic acid, levetiracetam, or phenobarbital. You could use ketamine, but that's not really used very commonly. But all of these first drugs, like I said, they're all benzodiazepines, they're all GABA. All their adverse effects are relatively the same, such as sedation and amnesia and confusion in the elderly, things like that. And when addressing status epilepticus, you want to think about, why did they have a seizure? Could it be an electrolyte disturbance? Could it be hypoglycemia, drug withdrawal, anti-epileptic drug withdrawal, CVA, so stroke, tumor, or trauma? For someone who's coming in with an asthma attack, consider oxygen, their oxygen sat. Just figure out if they have any acid-base abnormalities. Give IV fluids, and then this is the key here: nebulized albuterol and ipratropium, and then IV. So these are beta-2 agonists, I believe. At least albuterol is. So they're gonna bronchodilate. They're gonna open your airways so that they can breathe. And then IV methylprednisolone, which is corticosteroid to reduce inflammation, and then magnesium as an IV piggyback. And I think, no, never mind. For alcohol withdrawal. So alcohol withdrawal can begin within a few hours after they stop drinking alcohol, and it can last for several days, 3 to 5 days. They might present with a tremor, tachycardia, diaphoresis, anxiety, nausea, vomiting, audio-visual disturbances, and seizures. So you can use this CWA tool to kind of score how bad their withdrawal is. And then from there, you can pick whatever options you think are necessary. You can use benzodiazepines if they're having seizure activity. You can use, you want to give them IV fluids, such as with a banana bag, which has a bunch of stuff in it, like vitamins, has thiamine, folic acid, vitamin K, magnesium, potassium. And again, if they're seizing, give them lorazepam. But long term, if they want to keep them off of alcohol, you can use disulfiram or antabuse, naltrexone, which is a narcotic antagonist, and it reduces cravings. So even though it's narcotics, it still has an effect with alcohol. And then clonidine can decrease anxiety, and then you can also use a camprosate. So this is a picture from our psych unit. So here is our picture for our vitamins. You have your banana bag right here, which has magnesium. So we have a magazine for magnesium. It's got folic acid in it, so a full for folic acid. This picture is pointing at the thigh for thiamine. Vitamin K is found in leafy green vegetables, which is why we have that. Bananas for potassium, and then of course just fluids and dextrose in normal saline. This is your disulfiram or antabuse. So we have an abused ant. So this is the ant from Bug's Life, and he has a black eye because he was abused. And this inhibits aldehyde, which is why we have an animal hide here. Anyway, it's just going to deter them from drinking alcohol because they're going to throw up if they drink alcohol and have this at the same time. And this ant, he is going camping. He's at a campsite, so a camprosate. And this is also, it increases the activity of GABA. So that's why I have a raccoon digging around in the garbage. And he's got a big butt. Decreases the activity of his glutes. Anyway, so that's for alcohol. Next, if we want to treat a CVA, you can give TPA. He said to know this dose. So 0.9 milligrams per kilogram with a maximum dose of 90 milligrams. And it's given as a 10% IV bolus over 1 minute. And then the remaining 90% is given as an infusion over the next hour. Next is PE. So you can use direct oral anticoagulants or IV heparin infusion or sub-Q enoxaparin or dalteparin or fondaparinux. Pretty much the same thing as DVT. And if it's a really big PE and they're hemodynamically unstable, you can give alteplase, which is similar to TPA. For DIC, disseminated intravascular coagulation, I believe is what it stands for, you want to give heparin, activated protein C, which is bold just because I don't remember talking about that before, IV fluids, fresh frozen plasma, and packed red blood cells. So the way to remember this, I said when someone is being a dick, DIC, you want to hit them with a chair. So chair. So the C in chair is for cells, and we're talking about platelets in this case. The H stands for heparin. The A stands for activated protein C. The I stands for IV fluids. And then the R stands for red blood cells. So when someone's being a dick, hit them with the chair, platelets, heparin, activated protein C, IV fluids, red blood cells. For anaphylaxis, you want to use, of course, epinephrine. You can use an antihistamine such as diphenhydramine and cimetidine, and then corticosteroids such as prednisone and methylprednisolone. And those are corticosteroids decrease inflammation. Epinephrine, of course, kind of helps open your airways and vasodilate and stuff. Oh, I meant vasoconstricts. My apologies. Epinephrine vasoconstricts. And then, so yeah, we'll move on to GI bleeds. So if someone comes in with the GI bleed, you want to make them NPO, so no nothing by mouth. You can give them, again, famotidine, which is that H2 blocker, and pantoprazole, which was a PPI, and then IV fluids. And so to remember this, I said, gee, I guess I better put my pants on for my family dinner. So GI, the GI bleed, I better put my pants on, pantoprazole for my family dinner. Famotidine. So, code blue, cardiac arrest. I said, aim for the heart. Aim spelled really weird, but aim for the heart with cardiac arrest. So they're kind of out of order here because that's, how the mnemonic makes sense. But anyway, so A could be for atropine or amiodarone. M is for magnesium, and E is for epinephrine. And of course, not all of those are used in cardiac arrest. ACLS here is referring to the bradycardia, the tachycardia, etc. So finally, I'm going to finish up with a chart that I made that is substances that you can overdose on, how the overdose is going to present, and then the treatment and reversal agent. So we'll start with just this general using activated charcoal. It's not very specific. It just says if you ingest something, but it can't be organic like antifreeze, and it can't be a metal or a caustic agent. It has to be an ingestion of something recent, but serious toxicity is likely, and the patient is still alert, cooperative, has a patent airway, and has no ileus or GI obstruction. So there's a lot of contraindications here for using activated charcoal, but you could use that. And if you want to do a whole bowel irrigation, you can use polyethylene glycol, which is that glow lightly stuff, which is going to make you crap your pants, basically. Of course, we all know if you overdose on opioids, you get Narcan. Gonna kind of skip over that one. For cocaine overdose, they'll present with hypertension, hyperthermia, anxiety. So everything with cocaine is just increased. And so you want to slow that down with a benzo and labetalol. You can also use nitroprusside, nitroglycerin, sodium bicarb. So again, like I said, with cocaine, everything's increased. You're hypertensive, hyperthermia, your heart rate's super fast, so you're anxious. So benzodiazepine is gonna slow things down. Labetalol is gonna slow things down. Nitroglycerin is gonna open your blood vessels and make you hypotension to kind of decrease the hypertension. If you were to overdose on a benzodiazepine, which would lead to CNS depression, respiratory depression, you would give flumazenil. And so the way I tried to remember this, I said, if it was a days in the maze, that's supposed to be like a days, because benzodiazepine. So there was a days in the maze, because this is flumazenil. So days in the maze by benzodiazepine, flumazenil. Yeah, whatever. All right, moving on. Sorry. Acetaminophen causes liver toxicity, coma, death. That's how it's going to present. And so you want to use N-acetylcysteine for an acetaminophen overdose. Best way I can remember that is that they both begin with the word ACE. So for ACE acetaminophen, you give acetylcysteine. For a TCA, tricyclic antidepressant overdose, they're going to present with cardiac toxicity, hypotension, seizures, coma, hyperthermia. I'm going to give a sodium bicarb infusion and a lipid infusion. And so the way to remember this is I crashed my tricycle, so now I need a car. So tricycle is for tricyclic antidepressants, and I need a new car for bicarb. Next is a serotonin overdose. So those are things like Zoloft, Paxil, Prozac. It could be just from drug interactions or even herbal products that can cause serotonin overdose. They're going to present with agitation, anxiety, hypertension, diarrhea, cardiac rhythm disturbance, and you give them cyproheptadine. So I said, give the psychos Cypro, the psychos Cypro. So, because most of these are drugs for like, depression. So, psych, and then cyproheptadine. You can also give benzodiazepines as well. Next is warfarin. Of course, warfarin, if you have too much of it, it's going to cause bleeding. So vitamin K is your reversal factor. You can also give activated factor 7 and then 4-factor prothrombin concentrate, which is Kcentra. So to help you remember this, so it's warfarin. I said if you go to war, you bring your AK-47. So ignore the A, but you have AK-47. So K is for vitamin K. 4 is for that 4-factor thrombin, and then 7 is for your Novo 7, or your activated factor 7. Heparin, again, presents with bleeding, and your antidote is protamine sulfate. So I always thought that heparin sounded like a hairpin. And so hairpins keep your hair out of my selfies. So that's because like my selfies, because protamine or protamine, and then sulfate, like a selfie. Next is the bigatran, and again, causes bleeding. To combat this, you can use dialysis or adairusizumab. And so the way I remember this is that the brand name is Pradaxa, and I think of the movie The Devil Wears Prada, Pradaxa. And so when I think devil and Pradaxa, or Devil Wears Prada, well, then I think like Daredevil. And I dare you, Sizumab is the antidote. So Devil Wears Prada and Daredevil. Next is your rivaroxaban and apixaban. Again, causes bleeding. Antidote is coag factor 10A and andexanet or andexa. So you use a net in the river. So this right here, this andexa net, you use a net in the river, rivaroxaban. For local anesthetics, they'll present with CNS depression, I believe, bradycardia, cardiac dysrhythmias, and hypotension. And the antidote is IV lipid emulsion. So I got local in my lip. I just liked the L's, local in my lip. So local anesthetic, you get a lipid emulsion. For paralytic agents, so that's things like succinylcholine, atracurium, cistracurium. This presents with prolonged skeletal muscle and diaphragm paralysis. The antidote is neostigmine, plus or minus atropine or glycopyrrolate. And so these drugs are all used in surgery, right? And so I'm thinking of a person who is getting a new knee. They're getting their knee replaced. They go into surgery to get a knee replacement, like a robotic knee. And instead, they got neostigmine. So instead of a new knee, they got neostigmine. I just thought that kind of rhymed. So that's another far-fetched one. Again, just a reminder, malignant hypothermia, treat it with dantrolene. If someone overdosed or swallowed, not overdosed, but swallowed antifreeze, they're going to present with metabolic acidosis, acute renal failure, coma, and death. You can give someprazole, which is your drug of choice, ethyl alcohol, thiamine, folic acid, pyridoxine, and calcium IV supplement. And unfortunately, I could not think of a good way to come up with this. but the brand name does have anti-Zol in it, so antifreeze, anti-Zol. Next is cyanide poisoning. So this can be from smoke inhalation, chemical exposure, apricot pits apparently, cigarette smoke. They're going to present with suffocation, hypoxia. And the treatment for this is sodium nitrite, or hydroxycobalamin. Y'all know I can't pronounce these words. Again, I don't have a great way to remember this one either. So we'll move on to organophosphates. So symptoms are sludge. If you don't remember them, look it up. But basically, anything that can leak out of your body is gonna leak out of your body. You're gonna be like crying, and your nose is gonna be running and drooling, and probably crapping your pants again. So, antidote is pralidoxime plus atropine, and you could consider benzodiazepine as well. And so the way I remember this, so organophosphates are usually associated with like fertilizing. And so this guy, he's like, wow, I was out fertilizing in the prairie. I saw an ox. And so I got scared and I jumped in a pine. So he was fertilizing, so organophosphates. And he was out on the prairie, so prairie for pralidoxime. And then he saw an ox. Oh, that's also with this word, the pralioxamine. So he's on the prairie and saw an ox. And so he jumped in a pine. So that's for atropine, like he jumped into a pine, atropine, atropine. Next is potassium, which also known as hyperkalemia. They'll present with cardiac dysrhythmias and weakness. So you can give IV insulin to kind of push that potassium into the cells. You can give IV dextrose, IV calcium, and then PO or PR, sodium polystyrene sulfonate. And so here's the way I remember this. So every time I think potassium, I think bananas. Bananas kind of look like dicks, right? That's how they always are like, oh, this is how you put the condom on the banana. You know what I mean? So dicks, we're going to spell it a little bit differently. DICS. So D is for dextrose, I is for insulin, C is for calcium, and S is for your sodium polystyrene sulfonate. So S is like either sodium or sulfonate, however you want. Next, if you overdose on magnesium, you'll present with hypotension, decreased reflexes, nausea, flushing, paralysis, respiratory failure, and bradycardia. You give them calcium. So in math, now I'm just focusing on the fact that magnesium and math both start with the letters MA. So in math, you calculate stuff. Calculate calcium. So in magnesium, give calcium. If you were to overdose on calcium, you'll present with weakness, decreased reflexes, confusion, nausea, vomiting, anorexia. If you overdose on calcium, you want to give IV pamidronate or other bisphosphonates. Now remember, bisphosphonates were used with osteoporosis, so I think that one makes sense to me because it'll, I don't know, something with calcium and bones and whatnot, I don't know, just makes sense to me. Moving on to lead, you give this EDTA, editate calcium dice, whatever. Don't have a good way to remember that one either. Iron presents with GI corrosion, liver toxicity, metabolic acidosis. You would treat with deferoxamine or desferal. And so I think of a feral fox. So foxes they're rusty, sort of iron colored, and they're feral, right? Because it's a wild fox. So iron, like a rusty fox that looks feral. So if you overdose on iron, give desferal. Digoxin, this one's pretty easy. You just give Digibind. it binds to the digoxin. Beta blockers. I said, you better not lie to me. You better not lie to me. So lie is for lipid, I is for insulin, E is for epi. So you want to, if you overdose on a beta blocker, you want to give epinephrine, an IV lipid emulsion, high dose insulin infusion. And all of that is just to help increase your cardiac output and blood pressure. And I must have missed this one. I made my little mnemonic, but you can do a glucagon infusion as well. Okay, calcium channel blockers. You can give calcium, high dose insulin, glucagon, and lipid emulsion. And so the way to remember this, I said you, instead of click the button to change the channel, you glick the button to change the channel. So glick is G, glucagon, L is lipid, I is insulin, and C is calcium. And then, of course, you're changing a channel because this is a calcium channel blocker. Okay, so if there's some cardiac testing drugs such as adenosine, dipridamol, rigadenosone, and to treat those, you can give aminophylline, theophylline, because those are adenosine receptor antagonists. And so I said, if you make a scene, use the phylines. So adenosine, if you make a scene, use the phylines. These both end in phylline. For aspirin, you can give sodium bicarb, desmopressin, and then this factor 7A. And so I said, my ass hurts. I need a new car where my butt won't press into the seat as much. So ass hurts for aspirin. And then I need a new car for bicarb. And then where it won't press into the seat. So that's for desmopressin. And then last but not least, we have our vasoconstrictors such as dopamine, phenylephrine, norepinephrine, and dobutamine. And so if you overdose on those, you can give phentolamine, which is an alpha-1 blocker. And I didn't know how to remember this other than the fact that literally all of these vasoconstrictors end in the word mine, and so does phentolamine. And so that is all of it. I'm very happy to be done. Thank you all for watching and supporting me through my Pharm videos. Good luck.